A very good morning to all of you. Welcome to the March episode of Monthly Clinical Lecture Series organized by the Doctors Welfare Society of LRH. Actually, this is the fourth installment. I think we have been with us since the first. We initially did the common ENT problems in childhood, then the common skin disorders. The third one was common eye disorders, and now we have another again a very important topic in pediatrics, childhood asthma, tips to achieve a better control. So to deliver this lecture, there's no better person in all LRH than Dr. Our very own Dr. Channa De Silva, the first consultant pediatric pulmonologist in Sri Lanka. Dear sir, over to you to conduct your timely lecture.
Very good morning to you all. First, I would like to thank Dr. Vasan and the whole team of the Doctors Welfare Society of Belarus arranging this type of CME activities as well as providing these updates on the management of common conditions in children and inviting me for this session. So here I am focusing about the asthma, which is the commonest chronic disease in child, which leading to a significant morbidity and mortality in children. As we know about asthma, many things knows about asthma. Throughout the world, many people knows about asthma. There are many developments in about asthma, especially during last few decades. But still, it's a significant conditions which leading to significant morbidity and mortality, especially in children. So, its important thing is still, with this much of understanding of the disease as well as the management and the sophisticated methods available, still there are issues with the, especially the diagnosis of asthma. Even there are overdiagnosis, many overdiagnosis of asthma, and still there are underdiagnosis. As well as the problem is still to achieve the control. Whatever the available methods, still children are suffering from asthma. The asthma control is poor in many setups, which can be managed with simple, very simple measures, especially with simple tips. And so because of that, it's very important to focus on the very simple things, basic things, again with the proper method to achieve asthma control in children, because still asthma is a very challenging condition throughout the world. It is not limited to our setup. Straight away, I'll discuss with few steps, very important points, because we know about asthma many things, but I would like to start with the diagnosis. So the definition of asthma, first thing is that if we want to achieve asthma control in the child, first thing is you have to make sure this child is actually having asthma. That's the first thing. Because sometimes I'll go through these few case scenarios as well. The diagnosis is important because the clinical symptoms of asthma, especially small children, especially preschool children, can be due to some other conditions also. The cough, wheezing, breathing difficulty, especially even this wheezing sound can be due to some other conditions, especially airway obstructions, initially present with exactly as asthma, but the diagnosis is completely different. And if we continue to manage with asthma, so obviously we cannot obtain proper control. So the diagnosis is important. The diagnosis now, the definitions. So the understanding of asthma has been changed over last few decades according to GINA. Unfortunately, we don't have a single sentence, very simple definition of asthma. It's a big definitions with few sentences which describe all the features, clinical pictures, pathological, physiological, and important findings which unique to asthma. Okay, but what are the important things in this definition of asthma? So if we break down these definitions, if we focus on the important aspects in these definitions, first thing they mentioned is it's a heterogeneous disease. That is one of the important thing, new development, new things which we have to understand very well, especially when we are managing children with asthma. I'll come to that in few minutes time. So obviously, it's due to chronic airway inflammations. That's the commonest chronic disease in any persons, not in the children, adults. This is a commonest chronic disorder and presents with mainly four core clinical symptoms. There are no other symptoms of asthma. It's just cough, wheezing, shortness of breath, and chest tightness. Those are the main clinical symptoms of asthma. And what is unique asthma is the symptoms vary over time and intensity. The usual term we are using from our medical student days is the reversible airway disease. Rather than telling this as reversible airway disease, they are using this new term, the new descriptions or the new way of giving that reversibility. Symptoms vary over time and intensity. And what's the primary patho? The physiological abnormality in asthma is variable expiratory airflow limitations. So it's happened due to variable expiratory airflow limitations. And other important thing is if this asthma being untreated or unattended or without giving proper treatment, sometimes this variability might be lost and sometimes children will end up with permanent changes, what are called remodeling. So it's important, it's heterogeneous disease, chronic disease with main clinical symptoms due to airway inflammations leading to expiratory airflow limitations, which is variable over time and intensity. That is asthma. If a child presents with such symptoms, we can diagnose it as asthma. But still, it is challenging, not that simple. Okay, so asthma. The term asthma we are using to describe children or people with cough, wheezing, and chest pain, shortness of breath. This is actually an umbrella term. If I use a similar example like anemia, anemia is a low hemoglobin, or the arthritis is an inflammation of joint. We know anemia is not a single disease, or arthritis is not a single disease. Under the umbrella of anemia, there are several conditions, several diseases. Arthritis is also same. The pathophysiology of osteoarthritis is completely different from rheumatoid arthritis. The course of actions, treatments, and all things are different because these are two different diseases. Asthma is exactly same. So it's not a single disease. That is one of the important points with the new development. Asthma is a heterogeneous disease. It's not a single disease. There are different endotypes or the pathophysiological processes, different phenotypes. We don't have time to go into details. But most important thing is we have to highlight it's not a single disease. Like anemia and arthritis, under the term, under the umbrella of asthma, there are different types of diseases. So what is important? So if you diagnose asthma in a child, so it's not the start of the journey. So because we have to identify which asthma this child is having. Still, it's difficult thing because still we know that what are the types of anemia, what are the types of arthritis, but still, unfortunately, we don't know what are the exact types of different types of asthma. But at least now we know asthma is not a single disease. So what is important is have an individualized approach in the diagnosis of asthma and the management of asthma in children. So then how do we diagnose these conditions with this background? Obviously, it's a clinical diagnosis. Whatever the available resources, available sophisticated tests, the diagnosis of asthma is clinical. So we have to assess if a child presenting with us with symptoms of or referral or with respiratory symptoms, we have to assess whether this child is having symptoms of asthma, cough, wheezing, breathlessness, and chest tightness, and we have to assess the variability of these symptoms. The symptoms which be variable according to the time of the day, according to the time of the year, or the seasonal variations which we don't see in our setup much, and variability according to triggers. And as this is a atopic diseases, family history and personal history, other atopic diseases, allergic rhinitis, eczema, it's important. And if child has been already treated, the response to usual treatment of asthma, bronchodilators, and if the symptoms recurs, with stopping these treatments, almost diagnostic of asthma. I just mentioned just as the sketch how to obtain a clinical diagnosis. As you all know, this is just to recap what you know. So why it is important? Have a proper diagnosis because there are many conditions, especially small children, preschoolers, which lead into false diagnosis, so which mimic asthma, various airway conditions. There may be the anatomical problems like tracheomalacia bronchitis, even congenital heart disease, recurrent respiratory infections, viral infections, because virus infection itself can give some sort of bronchospasms, but pathophysiology is completely different. It's not asthma. So that also can mimic asthma. Or sometimes aspirations, reflux, structural abnormalities, even premature babies, bronchopulmonary dysplasia, cystic fibrosis, celiac dyskinesia, various kinds of diseases, initial stage can present as the similar symptoms of asthma. So it's very important to have an open mind if you are dealing with a child, especially with uncontrolled symptoms. Why? What are the important things or pointers, or especially clinical features pointing towards such another diagnosis? So, it's whether it's not real asthma or not. So, what are called these red flag features? If the child is in persistent moist cough, that indicates possibly child is in some suppurative lung disease or bronchiectasis or cystic fibrosis or PCD, some sort of a different conditions rather than asthma. Isolated cough, asthma. The wheezing is a classic sign of asthma. There is a description, as you all know, cough variant asthma, but now there are some arguments without wheezing whether asthma can persist. Some queries about this diagnosis of cough variant asthma. If your child has only cough, then still it would be asthma, obviously, but you better be very cautious to need further evaluations. And symptoms starting since early infancy, because asthma is a allergic condition. Since early infancy, it's little unlikely, still possible, but if a child develop these symptoms within first few weeks of life, then it may be due to some structural abnormality of the lung or airway. Significant failure to thrive, finger clubbing, obviously indicating hypoxic conditions, interstitial lung disease like conditions, or suppurative lung conditions like bronchiectasis. Like that, various other clinical features, symptoms and signs, localized lung signs, family history, and the poor response treatment. All these things are important, pointing towards possible alternative diagnosis. For diagnosis of asthma, it's very important have a proper diagnosis. That's the first thing. So I just show a few cases, real cases I have come across during local and foreign training. There's a 3-year-old girl, recurrent severe wheezing episodes, managed at asthma, required admissions to PCU twice with ventilations. Bronchoscopy revealed, yes. So bronchoscopy revealed the narrowing of the mid trachea, and CT revealed there's a cystic lesions. Actually, it was a bronchogenic cyst, compression in the mid trachea leading to exam initially similar features of asthma, but it's definitely not true asthma, and this asthma has been cured with the surgical. Right. Another 6-month-old girl presented wheezing and cough, poor response to again initially managed as wheezing symptoms. And again, the bronchoscopy revealed narrowing of the mid trachea. Further evaluations revealed vascular ring obstructing the mid trachea. But initial symptoms was breathing difficulty and wheezing symptoms initially managed as asthma. And 11-month-old child, again, similar symptoms, persistent cough, breathing difficulty, and but without a history of wheezing. This is 2 months history. So this type of short presentation is very, very important. Do the imaging, the chest X-ray, you can see the hyperinflation of the right side of the lung and mediastinal shift to the left side. CT confirmed that, and the bronchoscopy revealed the foreign body in the right main bronchus, causing significant obstruction. Another 1-year-old boy, recurrent and persistent wheeze episode, despite adequate management. The bronchoscopy reveals this narrowing of the, as you can see, these two bulges. You can compare with the normal trachea. This is normal trachea, and these two bulges causing some significant obstruction of the trachea, the subglottic area. This was a hemangioma. Actually, hemangioma causing these similar symptoms, and this hemangioma, as we know, propranolol is contraindicated for asthma, but this child's query or so-called asthma has been cured with propranolol. 6-month-old child, again similar symptoms. This child had multiple bronchomalacia. I will note in the multiple sections. Like that, various kinds of mimics or the way they are. So we have to have proper diagnosis. The important thing is, obviously, these are very, very rare, but still, if you can diagnose at least one in your lifetime, it's very important, life-saving. Sometimes these children might be continuously treating as asthma with various different types of inhalers. So the clinical diagnosis, there's asthma is very high probability if the symptoms, typical symptoms are there, the variability, recurrent nature, family history, and A to B, and no other features or no other red flag signs, then the very high possibility of asthma. Intermediate possibility, if the all the features are not there, but some features, but the asthma clinical diagnosis is unlikely or the probability is low if there are no the typical features are absent, plus the red flags features are present. So how this is how we approach clinically in the diagnosis of asthma. So first thing is diagnose it properly, and then you can confirm the diagnosis with an appropriate pulmonary function test, but small children it's difficult. Sometimes practical difficulties are the other thing is normal spirometry or normal lung function test does not exclude asthma. That's another important thing. So, but Gina, they recommend ideally have to do appropriate lung function testing every child before starting long-term management. That's the ideal way. But first thing is asthma diagnosis clinical and if possible, confirm with an appropriate lung function test. So what are the available tests? We have the spirometry. I'm not going to do details of these individual testing. We can do the bronchodilator reversibility if the reversibility, the FEV1 changes more than 12%, that is confirmatory of reversible airway disease or asthma. Or we can use our simple peak flow meter and we have to assess it a regular period at least 2 weeks and we have to get the diurnal variations according to this formula. This is GINA. If the variable is significant more than 13%, that is again diagnostic of asthma. And here we have to get the days highest and the days lowest divided by the mean, not the previous value, the lowest value, the mean value. That's the important thing. If that is more than 13%, that is again diagnostic of asthma or the significant diurnal variation is there. There are some other sophisticated methods available like impulse dosimetry, infant PFT, and some even the plethysmography. But practically, the spirometry is the most important available lung function test to diagnose asthma in children. Okay, so once you diagnose it properly, now the new approach, phenotypic approach, if we can identify the what is exact type of asthma in children, it's very important to have the control, have the management, and especially assess the prognosis. So now world is moving towards this, but as I mentioned, still we don't know what are the exact types of asthma phenotypes because various kinds of factors affect the final outcomes. Genetics, environment, microbiome, the infections, all these things are there, and our management, all these things finally lead into the different types of phenotypes with the background of internal changes like what you are called these endotypes or the inflammatory pathways, whether it may be Th2 predominant pathway or the Th1 predominant pathway. So simply it's a complex thing, but clinical ground, if possible, better to identify what is the exact type of asthma in this child. For example, like preschool wheezes, earlier this has been classified as episodic viral wheeze or multiple trigger wheeze, but soon after this publication, 2008, there were various articles challenging this. Obviously, we cannot simply divide preschool asthma into two categories because various categories are there, various differences are there, very significant variation is there. So, but just to have this idea, the episodic viral diseases are the children who develop the asthma episodes with the viral infections, but in between episodes, they are normal. And the multiple trigger diseases develop the infections related wheezing plus in between episodes also with other type of triggers, the what we all know, all these triggers having the symptoms. Those are the people who are having true eosinophilic mediated asthma, which can progress to future long-term asthma. But viral induced wheezes usually settles after 5 to 6 years of age. So whether identification of this pattern is important. But other thing is sometimes viral induced wheezes might not respond to the usual Indian corticosteroid or steroid management because their inflammation is different. So most of the time it's not the eosinophilic mediated type 1 typical allergic reactions, it's neutrophilic mediated reactions. So like that, there are some differences at least to identify the possible type of asthma. And the earlier there were a definition according to severity, mild to severe disease, and episodic to continuous disease. So like that, the mild continuous, mild episodic or severe continuous, like that. So as you all know, this classification also now out. We don't use this. Now mainly asthma defined according to the control or the step, the control-based assessment or control-based management is going on. Plus so the problem is still, as I mentioned, we don't have proper definition, proper identification, proper classification of phenotypes, but still we have to have some idea what are the available things like allergic asthma, non-allergic asthma. This is GINA, adult onset asthma, asthma with persistent airflow limitation, asthma with obese, like that. Some different forms are there. So most important thing is it's a heterogeneous conditions. We have to have some individualized approach in the management. At least if we know this child's asthma completely will be different from others' asthma, so then we have to have a proper individualized approach in the management. So that is another tip, controlling asthma, individualized approach in the management, because the underlying the problems or the pathophysiology and the phenotypes all would be different from individual children, even the siblings of the same family. Okay, so next, obviously, once you diagnose, if you can identify the phenotypes, that's fine, but sometimes practically not, sometimes most of the time practically difficult. But fortunately, whatever the underlying this phenotypes or different categories, most of the time they respond to inhaled corticosteroid, except some forms of viral induced diseases. So the pharmacological management is the most important thing, long-term management to achieve symptom control of asthma. So what are the options? And we are using this stepwise approach. The goal is obviously to achieve and control the symptoms and maintain the symptoms control, allow the child to have normal activities, allow them to have their normal growth, allow them to have their normal lung functions, and prevent or minimize the long-term changes. Achieving all these things, we have to prevent or minimize the side effects of drugs as well. So we can give oral corticosteroid, long durations, we can achieve all these things, but that lead to obviously side effects. That's why, so selecting the method, pharmacological method, it's very important to address that aspect as well, prevent or minimize the side effects as much as possible. Those are the main goals of treatment. So to achieve these things, now world, as you all know, using this stepwise approach is a control-based assessment, control-based management. According to the control, we adjust the all these manage. So we have, it's a cycle. We have to review the response. We have to assess the child, adjust the treatment, again review the response to this cycle. So it's not a single point of care thing. It's a process. We have to follow up these patients. Always we have to assess whether our management is correct. If it is not correct or if it is, there are problems, we have to adjust our treatment, have to adjust their environment, and again review. And so this cycle should go. So it's a dynamic process. For that, as you know, we are using this stepwise approach. So I'm going to go to details about these individual stepwise things. According to the age, so we are mainly following this GINA, preschoolers, children 6 years to 12 years and above 12 years. They have categorized 3 categories, and the management is stepwise approach, depending on the frequency and the severity of symptoms. So initial management, according to this GINA, depending on the frequency and the severity of symptoms, we can initially judge the what is the possible the step, and then with that we can go step up and down. For children 6 to 12 years also, there's different steps. Right. And this is another new thing. So the world is moving towards use of the single inhaler technique rather than using 2 inhalers with the controller plus reliever. So same controller medicines can be used as a the reliever as well. So that is mainly with the formoterol. It's only with formoterol. Formoterol is, as you know, LABA, long-acting bronchodilator agent. But unlike salmeterol, formoterol onset of action is rapid. It's almost equal as salbutamol. So because of that, we can use it as a reliever as well, but we cannot do it with salmeterol. So now more studies are going on, more evidence are appearing. Use of this single inhaler at increase the compliance as well. If a child is having symptoms and they can use the same inhaler few more times rather than the routine or the daily twice a day dose, and that will give more bronchodilator as well as additional steroid dose also. So this is the concept of this single inhaler therapy or MART, or the maintenance and reliever therapy with the same inhaler. This is being practiced in many countries. Now world is moving towards this because it's initially the evidence appeared in the adult patients. So because of that, GINA recommend mainly for all 12 years, but now up to 60, above 60 also, they recommend as an optional method. It's like this. So the control and prepared. Prepared reliever is this ICS and Prometro. So about LAs, that's the prepared one. The alternative one is the now they are being the routine one. So yes, so this is a MART therapy. Still not widely practiced in our setup, but world is moving towards this. Right. Then, so maintenance of treatment. We have to arrange the follow-up properly. We have to assess them properly, and we have to assess whether this child is in appropriate management. So I'm not going to the individual drugs. So this just discussing the principles of achieving control. So other important thing is adherence to treatment. That is one of the most important, very simple factor which we can use properly to achieve asthma control. That is one of the main reasons actually they are not achieving asthma control, because usually most of the time we are not doing miracles, but if the child is using this inhaler properly, usually parents are coming with very good results, and they are amazing with how doctor may have done like that, because most of the time it's just the compliance. We didn't do much, it's just the compliance. So that is very important. Proper adherence to treatment with the proper inhaler technique, that's one of the most important practical things, practical tips to achieve asthma control in our setup, because our setup, they are very reluctant to use long-term treatment, especially asthma-like condition. When the child is in normal state, they just stop this, right? So there's a way, there are various methods you can use to assess the adherence. For example, if the dose counter is there, you can calculate the dose counter, the number of connectors, and simply asking the question. But sometimes it might be difficult to directly asking, but we have to use some methods to assess the proprietaries. And according to the response clinical symptoms, we can step up, step down according to the child's clinical response. So as I mentioned, one of the important thing is to use a proper inhaler technique. So it's very important to use the age appropriate inhaler method, inhaler technique, devices, and have to assess the what is the best method of using this or delivering the aerosols into the breathing tubes. So we are using, obviously, we are using the inhaler or the inhale medications. Inhaler medication is just giving the drug directly into the breathing tubes, or the where the problem is there. For example, it's like putting. So you can use these terms with the patients also. If the patients is just reluctant, especially parents are reluctant to start this and in long-term inhaler steroids, just you can mention it's just putting eye drop into eye for a eye disease. So usually they don't bother putting eye drops into eye. So because it's a short-term thing. But here the problem is asthma, wheezing is a long-term conditions. That's why they are worried, because there's a myth, obviously, if we start these inhalers, it's long-term, and this get used to this. It's mega patangato that that's a usual problem in our setup. So that's why it's very important to stress that asthma is a long-term conditions. That's why we are giving these inhalers for long term. And that's why, and it's now inhaler doesn't cause the disease. You have to use that term very properly. Inhaler doesn't lead to disease. So that's a, this is a treatment. If you prematurely stop that while the disease is going on, then automatically disease will flare up. So that's why we have to use it long term. So this education is very important. And we are using this is a topical treatment, like applying a cream or something to joint problem. It's a topical treatment. Directly we are giving the drug into the place of site of problem. So those things are important to educate parents to get on board with our management. So the lung deposition, that's an important thing. Whatever the methods, whatever the duct, whatever the dose we are using, it should reach the lung. So that's a problem when we are using the inhaler or the topical treatment. Okay, so that's why most of the time they don't achieve proper control. So lung deposition, the number of particles reaching the distal airway is the most important thing. Most of the time with the poor techniques, these particles which reach the only the stay at the throat or the major airways, will not reach the distal airway. That's a problem. That's the most of the time reasons to achieve poor control. Because it's not a simple thing like drinking water. So drinking water is straight away goes to the stomach, but here it's not a simple thing. It's a complex things, complex physics is there. and these small particles deposit in the the airway with three mechanisms: impaction, sedimentation, deposition. Impaction is the direct impact leading to the deposition of large particles at the site of impaction. So because the problem is this, the airway is like this. It's not a simple single tube. It's divide, 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 and divide up to 23 times. And when the airflow comes here, it should hit here, and then again this like this. So it should travel to a long durations, long path till it reach the final, especially the small airways, where the give rise to maximum significant resistance, expiratory airflow limitations. So that's very important. So the impactions happen in the major airways, and the sedimentation is the most important mechanisms which deposit the particles within the airway. That is like this, due to gravitational effects, these particles get like we put some mud into a water bottle and we just mix it, and when we keep it outside, and gradually with the gravitation it sediment. The same things, these particles will dissolve within the air, will deposit within the airway with the sedimentation trap. Okay. So, and the diffusion is the small particles movements. It's a little complicated thing, usually not important. We have to reduce the impaction, because the impactions mainly happen in the air, the pharynx and the large airways. Here, we have to increase the sedimentations, and diffusion we cannot change. Why it is important? So this is the problem. If we do not use it properly, especially these MDIs, the lung diffusion would be significantly low. It would be even low as 5%. 95% reach the gut, liver, and then enter into the systemic circulation. So this is the most important part here. Okay, so then what would be the most important, or the most important method of delivering aerosols into the small airway with minimum side effects? Best method of long-term medication delivery into the respiratory systems. Yes. So this graph will give very nice summary. If you focus on this, this is just the MDI without any spacer. The brown color or the maroon color indicate the oropharyngeal deposition. The blue color indicate lung deposition. And this is device deposition, and exhale fraction is there. So we want to reduce this fraction, the oropharyngeal deposition. That is the one which will give rise to side effects, local as well as systemic, will be so low. We have to improve the lung deposition. Or with the pressurized MDI, just MDI alone, you can see the lung deposition is maximum 10%. Significant amount retained, the pharynx will give rise to side effects. And if we use a spacer, you can see significant reduction in this unwanted pharyngeal deposition and improve lung deposition, right? So this is with just non-static valve. If you use a static, the proper inhaler, the proper spacer, fortunately over the available spacers in our setup and the world at the moment contain these anti-static properties. So it can improve significantly the lung deposition, significantly reduce the pharyngeal deposition, and that's will the unwanted fractions which give rise to side effects now retain in the spacer. So the side effects will go to the spacer. Who cares? So that's the most important thing, to improve the lung deposition and reduce the oropharyngeal depositions, right? So DPI inhaler. So these are the important things. So we are using still DPI inhaler for children, but the first thing is DPI inhaler. They have generate peak inspirated flow more than 30 liters per minute. Small children, they cannot do it properly. Otherwise, it won't reduce, increase the particle size. Larger particles will retain in the lungs, the pharynx, significant amount, and the lung diffusion would be significantly low. Okay, so considering all these things, evidence supports the use of a spacer with the MDI, proper spacer, would be the best method of delivering aerosols into small children long term, that increase the lung deposition as well as reduce the systemic side effects due to local pharyngeal deposition. There are studies also. You can see this is with the MDI alone. This is with the MDI plus the spacer. Various studies, and here you can see without the spacer, significant amount of particles retained. So these are technetium 99 label studies. and a significant amount retained in the stomach and the esophagus, lung deposition. And here you can see the unwanted traction which retained in the pharynx, now retained in the spacer. So who cares? But the lung deposition has increased. You can see here significant difference when you're using the spacer. And this graph, this study, they have demonstrated that significant change in the lung deposition, increased lung deposition with reduction in the pharyngeal and the gut absorption. So it's very important to. So this is completely out without the spacer, even for adults. Children definitely no. So you have to use the spacer appropriately. Small children with the face mask and older children without the face mask. So that's also important just to use without the face mask. As soon as possible, if they can manage, better to remove the face mask and use it with the mouthpiece, because our nasal cavity, the normal natural function of our nasal cavity is to prevent the small particles enter into the lungs. So because of this, various mechanisms are there, plus the mucociliary clearance. So that will happen to same to the small particles we are giving also. So that's why as soon as possible we have to bypass the nasal cavity to get rid of that defect or to improve the lung deposition. Then the spacer. So various spaces are there. The how to select spacer, various things are there, but first thing is it should be obviously anti-static properties, but now we don't want to select that all the available spaces. Actually, the correct term is valve holding chamber. So contain valve. Space is anything, just a plastic or the rubber tube would be a spacer that will give some space. But the ideal or the correct thing is now we are using this valve holding chamber. It hold the particles till we inhale, and this valve thing prevent expiratory flow going into the chamber. Right. Okay. So I'll go through quickly the inhaler techniques, because the technique is most important thing. Yes. So as I mentioned, so the recommended method for all children is pressurized MDI plus the spacer. How do we use that? Yes, we have to shake it properly, because inside that, even this is a gas, it's a pressurized gas. Inside the MDI is contained as a liquid, like our LP gas cylinder, liquid form. The liquid problem is the propellant gas is there about 20 milliliter. The drug is about just 0.5 to 1 milliliter. If you don't shake it properly, just only the majority get the propellant gas only without the drug. So shaking is very important. Upright position is important. Sometimes still we see they are using other way, because the mechanism, the the drug, the liquid form is here and is coming through a small hole. That mechanism is activated. The chamber, there's a small beta dose chamber. That chamber is filled if it is we are keeping some upright position, because it's used the gravity. If we keep the other way, the drugs collect here and it won't retain, or the drug will not be evacuated. Okay, so upright position is important. And so, yes, obviously, the tight seal is important to get all the things inside the chest. And you have to, that's the important thing. So usually, like, for example, the salbutamol, we are giving 3 to 4 puffs at a time. But every time we have to give it 1 puff at a time. Sometimes we are still using, saying, sometimes 2 puffs together, 2 puffs like that. But every time we have to use it 1 puff at a time, because, so this one study very nicely, they have demonstrated that 1 activation, 2 activation, 3 activation. Actually, if you press it thrice together, the lung deposition will be significantly less than even the single activations. Why is that? Because these are small particles. The small particles, the mass median aerodynamic diameter is the most important thing. It's not a simple like that. That's why mentioned is not like giving water into the stomach. So this is a little different thing. These small aerosol particles, they group together form larger particles. If we fill the small spacer with 3 to 4 puffs together, all these forms larger particles, and larger particles will retain in the significant amount the spacer, and rest of it in the pharynx. That's why if you give more and more puff, the lung deposition will be reduced. If you want to give it properly, every time you have to give single puff at a time, one by one. Another thing is inhalation without delay. Sometimes we see the parents press it somewhere and then keep on the face. No, you have to keep on the face and then press it, because the delay, because these particles within the small space within the air, and then gradually they start to deposit with the same effect of gravity. So if the delay is more, the deposition is less, obviously, right? And they have to take 4 to 5 slow breath. The slow breath, the ideal method is the single breath. You take slow breath and hold it for 10 seconds. That is to allow this deposition, improve the sedimentation. But small children, they cannot do it properly. So because of that, we ask them to take 5 to 6 single breath, slow tidal breath. That's also important. But they should not blow it. That's the important thing. Slow breath, very slowly, to allow the deposition, some time to deposit these particles within the lung. So that's very important, because most of the time children are focusing on expiration. That should not be done, because this particle, there's no time to deposit within the small airways, right? If possible, then hold breath for 10 seconds. That's the different method, single breath method or the multiple breath method. If child cannot do that, then they can take slow 5 to 6 breaths. 5 to 6 breath would be enough, because all these things depend on the volume of the space and the tidal breath of the child. Ideally, within first 10 seconds, this should be empty, but with the time, as I showed earlier, gradually these particles get deposited in the spacer. If we keep 10 to 15 minutes, no point. More than 10 seconds, no point. So maximum 10 breaths would be enough. 50 to 20, 30, even 100 breaths, the effect is same, because nothing inside the spacer after about 10 seconds. That's the reason. Okay. And then once you activated, do the same thing. And if you want to give the second puff, wait at least about 30 seconds, because that is again the important thing. Because as I mentioned, inside this canister, it is the gases are in the pressurized gas as liquid form, and the temperature is minus 30. Can you believe that? Yes. So it's a pressurized gas. Inside it's a minus 30, and it's going through the small hole here. Once it's minus 30, gas is going to a small hole. The physical properties of this small hole will be changed. Actually, it gets shrink. And if you do the puff again, the next dose won't be 100 micrograms or whatever you. That's why we have to allow little time to again it come to the room temperature to become its a normal size. So as I mentioned, all these steps have a purpose. It's not a simple medicine. A lot of physics is there. And obviously, if you are giving the second puff, again, you have to shake. And obviously, as you know, after using steroids, yes, obviously have to rinse them out, right? So, inhale technique is important. So, small infants, small children, we can use a MDI spacer plus a face mask. As I mentioned, if they can manage, after that, after about 5 to 6 years age, remove the face mask and use the spacer. The most important thing is this. We have to advise them properly. Why do we use this spacer? Why do we use this inhaler? What is the purpose? How long do we have to give it? At least about 3 months. So this education is important. And then demonstrate. How do we have to use? Just we have to demonstrate. Not just giving the instruction would not be enough. They are doing various things. So you have to demonstrate, and that's also not enough. Every time we have to check whether they are using this regularly. So advise, demonstrate, check it regularly. That's the way to achieve the simple, very, very simple tip to achieve asthma control in majority of children in our setup. Yes, then I'll go through the rest of the things little fast. Non-pharmacological management. So pharmacological management using the inhaler corticosteroid is the most important method. With that, there are some other things like avoiding triggers. There are various triggers, be air allergens, airway irritants, sometimes the infections. As much as sometimes it would be practically difficult to avoid these allergens or the environmental things, but at least like cigarette smoking, very, very simple way we can just avoid those things. And cigarette smoking is the environmental tobacco smoking, the term used medically. It's one of the recognized main factor which leading to uncontrolled symptoms. So as much as possible, avoid these triggers, improve physical activities, and other comorbid conditions. As I mentioned, there's a specific condition, specific entity called obesity-induced asthma. If a child is obese, weight reduction would be the key thing, not the inhalers, because their inflammatory changes would be different. The inflammation may be neutropenic, not the eosinophilic classical intervention, inflammations like that. So reflux can cause significant worsening of symptoms. All these things are important. Difference of this can be how to manage pharmacology, but the idea is not only the inhalers or the other medicines, some other measures also can be we can practice or advise them to achieve the control. Right. So how do we follow up? Yes, obviously, as I mentioned earlier, it's a cycle, dynamic thing. You have to arrange regular follow-up. You always have to check whether the patient is adhering to the treatment properly. So yes, depending on the child's clinical symptoms, severity of symptoms, and the response to treatment, we can arrange the frequency, maybe once a month, once in 3 months, like that. And we have to assess the symptom control as well as the risk factors for future exacerbation. Usually, we are assessing only the symptom control, but other important thing is to control these environmental risk factors as well as possible potential risk factors for future exacerbations. Currently, yes, we are usually used to use the asthma diaries and all these things, but most of the time now the GINA, they have simplified this without going into the details. The last 4 weeks symptom control is important, and that's also very, very simplified. Only 4 clinical features we are assessing: the daytime symptoms, any nighttime weakness, any activity limitation due to asthma, and use of reliever medication. Only those 4 features. With that, we categorize it as well controlled, partially controlled, or poorly controlled asthma. This sleep disturbances, because once a month, even once a month is significant if it is due to asthma. So like that, so simple 4 criteria we can assess the asthma control. So no need to maintain the long-term diary, but if possible, yes, but at least we can simplify to assess this well controlled, partially controlled, or poorly controlled asthma. Very, very simple. Right, stepping down, once you achieve this control, yes, ideally at least 3 months, child should have a proper control. And we know this. But other important thing is child shouldn't have risk factors for exacerbations. For example, child had very severe episode of asthma and required ICU admissions. Even that the first episodes, we have to start prophylaxis. And now, for example, 6-month child is well, symptoms are fully controlled. But still, we should not think at least for 1 year we have to continue, because that's a risk factor, because child might have another similar kind of episodes, and this next episode child might have even severe episode, even child might die like that. So there are various risk factors: obesity, low lung functions, eosinophil count is very high, ever intubated for asthma, lifetime risk factor for exacerbations. So probably you have to give the inhaled corticosteroid lifetime. Like that, various, all these things are in the GINA. Okay, so I'm not going to details about each and everything, but the principle is to stepping down, before stepping down, not only the control, consider there's a possible risk factors for exacerbation of asthma also, like that. So these are important to achieve proper control as well as get the control to prevent future episodes. Right. So stepping down, yes. So we are usually using the gradually we reducing it. There's no fixed method, but first thing is to consider whether it's a correct time to consider the stepping down. And what you are doing is usually first reduce add-on. For example, if you are using the Montelukast, we can stop that first, and then if the child is on combined inhaler, we can change to steroid on inhaler, and then the child is on steroid on inhaler, then we can reduce the dose by 20 to 50% at a time. Gradually, ideally they mentioned once in 3 months, like, but gradually we can do it according to child's clinical response. Yes, if a child is having uncontrolled symptoms, if all these measures, all the simple things has been done, if still, so this is a challenging things, yes, this type of situations we need further evaluation. But here, there are two entities: difficult to control asthma and actual severe therapy resistant asthma. So difficult to control asthma not always indicate severe asthma, or these are not synonyms. Difficult to control asthma would be due to various other reasons. Maybe the compliance would be poor. Whatever our advice, whatever the thing, still child might not do it properly. Sometimes there are some socio-economical issues. Sometimes their belief, all these things would be there, or there may be comorbidities causing further exacerbations. So that's very important to identify or categorize, very clearly identify whether it's actual severe asthma or therapy-resistant asthma, or actual these uncontrolled symptoms are due to difficult asthma due to some other reasons. Okay, obviously, again, always stepping up, check the technique, check the compliance, check the drug doses, and check whether there are exacerbating factors like this, maybe controllable factors, or other like house dust mites or other air allergens causing this problem, as we already discussed. Address those things again, always. That's why I'm again and again stressing before stepping up, before considering or before labeling this as a severe therapy-resistant asthma. Address all these things again and again. And then, if really you are suspecting these persistent allergies, persistent symptoms due to some ongoing allergen exposure, we can check it. We can do two methods, screen pick test, we can identify the allergen sensitization, or we can do the immune cap method to identify specific IgE level. But these should not be that at beginning. For example, sometimes the house dust mite would be positive. But then what can we do? Our practical setup is obviously we have to ask them to keep the environment clean, and to give that advice, we should not wait till the house dust mite specific IgE is positive. Okay, so this allergic testing and allergic the panel, all these things have to be done in a very later state with the uncontrolled symptoms only, to make some fine adjustment. But at the beginning should not be done, because that's a waste of money. Right. As I mentioned again, comorbidities, obesity, reflux, right? All these things we have to address. And sometimes these are not common things, but uh, as our trainees and all the here, as you know about this, sometimes uncontrolled symptoms would be due to some other things, complications like allergic bronchopulmonary aspergillosis. This is allergic reactions, type 1 hypersensitivity reaction to aspergillus fumigatus. So, yes, there are various methods to diagnose it. There are some changes, radiological changes. And if it is severe, actually, if it is severe asthma, then we can have some idea of this. What is this inflammation? Whether it's eosinophilic inflammation or something else. So the FeNO, the fractional exhaled nitric oxide, is a surrogate marker of eosinophilic airway inflammation. So usually the level should be less than 35. If more than that, indicate child is having uncontrolled eosinophilic airway inflammation. There's a very simple test. It's available at LRH at the moment, but machine is expensive, but the test is very simple to assess, get some idea about the persistence of eosinophilic airway infection. If it is the case, then yes, obviously there would be a places for higher doses of steroids. This like this simple machine. Right. And other countries, they use this airway sputum inflammatory, assess the sputum eosinophilic count, but this is not a standardized test, and usually we cannot get proper idea with this. Right. So if it is severe, actual severe asthma, yes, there are some other options. And actually, the number of children having this severe asthma uncontrolled challenging situation still in our setup also may be less than 10. Very small number. Majority of time with the simple measures we can arrange this control or achieve the control. For severe asthma, there are various methods, as we all know. We can use the combined inhaler, we can increase the dose. And the MART, the maintenance and reliever therapy, is now becoming recognizing as one of the again the tool to achieve asthma control. Sometimes we might have to use long-term theophyllis, and now some studies are going on where there's a place for macrolides. Still, the evidence are not that much convincing. Some evidence are appearing. Use of long-term macrolides to achieve asthma control. Other thing is vitamin D. Sometimes vitamin D deficiency can cause. Those are not the sole reasons, but some contributory factors. And now the tiotropium, the long-acting antimuscarinic agents, also been licensed or recommended to use in children over 6 years of age with uncontrolled or severe asthma. If the option is there's no other options, we might have to use long-term systemic corticosteroid, and the next step is to use biologics, which is not available in our setup yet. Other countries now it's been licensed. Different types of biologics are there, and this the omalizumab, the most popular one, anti-IgE, or the mepolizumab is available, anti-IL-5, like that, various anti-IL other component, and these the omalizumab, mepolizumab, and dupilumab, these are now licensed using children over 6 years. That means up to that level. So these are being using, and other newest one are now being mainly again, yes, recommended, but for all the children. So these therapies are available, but the required population for this type of therapies is very, very minimum, and most of the time we can manage them with our simple measures. So other important thing, if a child, despite all these our measures, if a child develop acute attack, so the here again another take home message, consider this acute attack as a fact-finding mission to find out what was the reason for this acute attack. So yes, obviously we have to manage the acute attack with the appropriate method. I'm not going to details of management acute asthma, but here the message is this. So attack in the asthma attack. So the 2017 is Lancet Commission is Western literature, obviously. So they have advised like this. We advocate replacing the inadequate term of exacerbations of flare-up with attack. The use like the heart attack, asthma lung attack. So that give rise to some alarming thing. So rather than using the loose term exacerbate, but obviously ours have used a different language, but even Western literature, rather than using exacerbation. So the flare-up, now the officially they recommend to use the term attack, asthma lung attack, as the term to nominate this or the describe acute exacerbations like heart attack, because it's very important to find out the reasons why this child developed this attack. That's the thing, because that is important to prevent future episodes. Most of the time we just treat and send them home, but again, sometimes practical difficulties are there in our practical setups with large number of crowded patients, but still, when the child presents with acute attacks, always look into the cause why this child developed these acute exacerbations. We are doing it most of the time, most of the patients, but actively we have to go into the reasons to identify the reasons to develop this acute attack. That's one of the important thing to achieve good control or prevent future exacerbations. So what would be the future? Can we prevent asthma or the primary preventions before developing any single episodes or single clinical feature of asthma or the asthma cure, secondary preventions? Could it be possible? Yes, various studies are going on to identify possible biomarkers which describe or identify the potential to develop asthma and address at that point or the primary preventions before developing attack or cure or disease modifying approach. Can we change these genes? Can we change these genetics? Can we change the internal environment? Can we change these endotypes? Still, we don't have a proper answer to this question. Still, we don't have methods to prevent asthma or cure asthma. So because of that, yes, to achieve asthma control, till world develop such a thing, we have to have a proper diagnosis. We have to identify possible phenotypes, if possible, to this phenotypic approach, appropriate pharmacological management. We all know, giving stepping up. Sometimes we have to add Montelukast or leukotriene receptor antagonist. Sometimes we have to add the long-acting bronchodilator agents. Sometimes we have to combine with appropriate step pattern, appropriate pharmacological management, long-term maintenance treatment. That is important, not just short-term. As well as a chronic disease, long-term disease, we have to do treatment long-term. Proper inhaler technique, I am stressing it again and again. Some non-pharmacological measures would be have a place. Even breathing exercises, I didn't mention about that, because small children, it's very difficult to get on board with this breathing exercises. So this type of other non-pharmacological measures, regular and proper follow-up is important. And if the child is having uncontrolled symptoms, referral to a tertiary center or to do the further evaluation. And finally, if the child again present with an acute attack, consider that attack as an attack again, some experience to prevent, identify the reasons and prevent further episodes. Thank you.